And our content will be the definition, clinical presentation, and pathophysiology, differential diagnosis, the types of hepatorenal syndrome, management, complication, and risk factor, and lastly, the prognosis. Sorry for that. We will proceed to the definition. The hepatorenal syndrome is a functional, reversible form of acute kidney injury in patients with acute or chronic severe liver disease in the absence of any other identifiable cause of the renal pathology. Is one of the many potential causes of acute kidney injury in patients with acute or chronic liver disease. Affected patients usually have portal hypertension due to cirrhosis, severe alcoholic hepatitis, metastatic tumor, and also can have permanent hepatic failure from any cause. This condition is a life-threatening complication with patients of having liver disease. Hepatorenal syndrome represents the end stage of sequence of reduction in renal perfusion induced by increasing the severe hepatic injury.
Saad, your slide, Waad,
I don't know. Yeah, I don't know really what's happening with the slide.
Press in the. You don't need to show it in PowerPoint. Yeah, show it like regular slide. No need to show it as PowerPoint.
Okay. Yes.
Try now.
Yes. For the clinical presentation, the patient will present with progressive rise in serum creatinine, normal urine sediment, and proteinuria, but less than 500 milligram per day, and low urine sodium excretion, oliguria. But keep in mind that not every patient will present with oliguria, especially in the early course of the disease. Regarding the examination, we will find the patient having jaundice, ascites, and later on the patient will be having hepatic encephalopathy, clinically significant coagulopathy, and resting low arterial blood pressure. What's the secret behind this disease? The main hypothesis of this disease in the past 20 years had been...
What?
Lecture.
Can you email your presentation to Dr. Ahmed so he can give us better screen sharing?
Okay.
Sorry everyone for the technical issues. While Dr.
Which will be caused by the danger signal inflammation or microvascular dysfunction that will lead to renal hypoperfusion and direct tubular damage. For the differential diagnosis, we have the glomerulonephritis, vasculitis, infection-related kidney injury, renal acute kidney injury, acute tubular necrosis, nephrotoxin medication like NSAID, diuretic, and etc., chronic kidney disease, and hemolytic uremic syndrome, IgA nephropathy, nephrotic syndrome, and shock. The diagnostic criteria, according to the Journal of Hepatology, consists of cirrhosis, acute liver failure, and acute and chronic liver failure, increase in the serum creatinine more than 0.3 milligram per deciliter within 48 hours, or increase in the 50% of the serum creatinine baseline, and or decrease in the urine output less than 0.5 ml per kg within the last 6 hours. The patient will have full, no, or partial response to 2 days administration of volume expansion with albumin, and to stop the diuresing, absence of shock, and no recent treatment with nephrotoxic medication, the absence of parenchymal disease, and suggestion of renal vasoconstriction with fractional excretion of sodium less than 0.2%. The type of hepatorenal syndrome, we have type 1 and type 2. Type 1, which is more acute and most serious type. The patient will have doubling in the serum creatinine in less than 2 weeks, and most of the children will have one or more precipitant event like infection or bleeding, and there is a response of the patient with diuresing, and 10% survival in this patient within 90 days without treatment. In contrast, hepatorenal syndrome type 2 is gradual and progressive, and the patient will not have a response to the diuresing, and will not have a precipitant event, and the median survival will be 6 months. In this diagram, according to the Journal of Hepatology, the classification of hepatorenal syndrome, type 1 will have absolute increase in the serum creatinine, 0.3 milligram per deciliter within 48 hours, and or decrease in urine output less than 5 ml per kg within 6 hours, and the presence of increased serum creatinine more than 50% in the past 3 months from the baseline. But hepatorenal syndrome type 2, which is called hepatorenal syndrome non-acute kidney injury, the patient will have glomerular filtration rate less than 60 ml per minute in less than 3 months, with absence of structural damage, and the presence of increased serum creatinine less than 50% of the patient basis within the 3 months. And the chronic hepatorenal syndrome type 2, the patient will have estimated glomerular filtration rate less than 60 ml within 3 months and more. On the next slide, it showed the diagram showed the patient response in the acute kidney injury. That the patient will have increase in the serum creatinine from day 0 until 48 hours, which goes with type 1, and increase in the serum creatinine more than 50% from the baseline within 3 months. But the next one will show the type 2 hepatorenal syndrome, that the patient from day 0 will progress the kidney function deterioration within the 3 months, and will be estimated by GFR less than 60 ml per minute, and serum creatinine increased within 50%, less than 50% from baseline. This is the acute. The chronic phase will have this deficiency for more than 3 months. According to the International Club of Ascites and Acute Kidney Injury, their criteria, which is mostly, as we see before in the previous diagnostic criteria, the presence of cirrhosis and ascites, diagnosis of acute kidney injury according to the ICA and acute kidney injury criteria, the absence of shock and no recent or recurrent use of nephrotoxic drug, no response to diuretic within 2 days, and no microscopic sign of structural kidney injury. Okay, we proceed for the workup. The hepatorenal syndrome is diagnosed by exclusion. We will have initial lab, the renal function test, but just keep in mind that both urea and creatinine will not be reliable to the severity of the patient, as it will be affected by the concomitant liver disease and decreased muscle mass and decreased the protein and meat intake. And the urine microscopy with analysis with the renal ultrasound imaging to be done to exclude the precipitating renal damage, if there is so. The renal biopsy is not indicated in the hepatorenal syndrome. It's indicated with patient that that with structural renal damage is questionable, right? Like abnormal urine sediment and the presence of proteinuria of more than 500 milligram per deciliter, and hematuria and renal ultrasound finding. For the treatment of hepatorenal syndrome, the aim of the medical treatment to improve the kidney perfusion by increasing the mean arterial pressure and intravascular volume expansion with combination of vasoactive agent and IV albumin, and the liver transplant should be considered at early stages. The management of acute kidney injury should be started immediately once the patient diagnosed with hepatorenal syndrome, and the patient should stop every nephrotoxic drug that he's using, diuretic beta blocker and NSAID and NSAID. Volume replacement should be used in accordance with the causes and severity of fluid loss. Randomized study have shown that vasoconstrictive, particularly terlipressin plus albumin, have significant improvement in renal function with patients with hepatorenal syndrome type 1. Patients who respond to the treatment with terlipressin plus albumin showed better survival than non-responder. In 3 meta-analysis of randomized trial, the use of terlipressin was associated with significant improvement in short-term survival. Norepinephrine and vasopressin with albumin shown to be improved in using in critical ill patient, but in non-critical patient, terlipressin was used with in association with albumin, and midrenone and octreotide with or without albumin can be used in alternative of terlipressin. Medical therapy usually is futile if there is no improvement within 2 weeks of starting the medical treatment. The other line of treatment, we have the renal replacement therapy, which is most commonly used in patients awaiting liver transplant and who's have possibility of improvement in liver function. Other modality of management, we have the transregular intrahepatic portosystemic shunting, but it's not usually used in the pediatric patient as they present critically mainly. And as we see here in the picture, the stent will be placed in the right branch of portal vein to the right hepatic vein to release the portal vein hypertension, and used in the patient with refractory ascites. The limitation of its uses due to its several complications, as we see in the increased rate of hepatic encephalopathy, worsening of liver function, bleeding, and risk of further kidney injury with IV contrast. Usually the patient will have low sodium diet, and the teams should be involved for this cases are nephrology, gastroenterology, vascular surgeon, and transplant surgeon. Risk factor for developing hepatorenal syndrome with patient who's diuretic refractory with ascites and spontaneous bacterial peritonitis and progressive liver dysfunction that even lead to GI bleeding. Complication, the patient might have irreversible liver failure, chronic disabling hepatic encephalopathy, death, and end-stage renal disease, and recurrent diuretic-resistant ascites. For the prognosis, it's overall increased the risk of mortality in children with liver disease, and the outcome of these patients is strongly dependent on the recovery of liver failure, either by medical or by liver transplant. The rate of renal recovery following improvement in liver failure is unpredictable, and a significant proportion of patients show recovery of renal function after successful liver transplant. As a take-home message, the hepatorenal syndrome is one of many potential causes of acute kidney injury in patients with acute or chronic liver disease. Affected patients usually have portal hypertension due to cirrhosis, severe alcoholic hepatitis, metastatic tumor, and in some cases, fulminant hepatic failure. Hepatorenal syndrome represents the end stage of sequences of reduction in renal perfusion induced by increasing severe hepatic injury. And hepatorenal syndrome is a diagnosis of exclusion associated with poor prognosis, and early initiation of referral to transplant center is crucial. Okay. These are my references, and thank you all for attending.
Thank you, Waad. Thank you, Waad, for your presentation. I'll leave the mic now for the question. Before that, I will ask Dr. Shawush, who is our senior GI in our talk, to let us know how many, Dr. Shawush, cases of hepatorenal syndrome you found in the past 10 years in our hospital.
Can you hear me?
Yeah, we hear you now. Go ahead.
Yeah, thank you. First, I would like to thank our ICU team, especially Dr. Adib and Dr. Haidar for managing this patient. We could manage this patient as much as we can, and we save the life, and we refer him to a transplant center for further management. And actually, let me just tell you about this patient who actually presented by the age of 2 years, where he presented with acute hepatic failure. And I couldn't follow him up to 4 months later, but he never been having normal liver function test, and most of the time he's having a little bit of coagulopathy with increasing INR. But I feel this patient is not behaving like any acute hepatic infection, and I feel that he's having something else. So I decided when the second admission for the last one, who was before referring to PICU, I tried to manage the coagulation, and we could manage to do a liver biopsy. His INR at that time was 4.5, and we could bring it down hardly after 2 weeks of extensive treatment. We do a liver biopsy and showed severe inflammation, and we could not figure out what maybe the most likely causes, because I thought of autoimmune hepatitis, and he's early actually age for Wilson disease, and could be metabolic diseases that maybe we need to start treatment, or he has no actually herbal medicine ingestion or taking any herbs, and he was not taking any medications. So actually, the patient deteriorated suddenly and transferred to PICU, where they managed very well, and we could transfer the patient by ICU team to Eastern Province, and they were so cooperative, and we would like to thank them for their cooperation. So actually, I did not face any case except this one was having Hepatorenal Syndrome. But this one is very interesting because this is an acute event, and you know that is quite high mortality if you don't have a good multidisciplinary team and good ICU care. But actually, I did not come across in my career to have any hepatorenal syndrome. And I think those who are working in hepatic or liver transplant center, I'm sure they face it, of course, more than gastroenterology managing all different cases of pediatric gastroenterology. So if our colleagues having anything they can share with us, especially those who are working in liver transplant, either in Riyadh or in Eastern Province, definitely they will face some of these cases. And thank you, Adiban, for your team.
Thank you. Anyone from GI consultant fellows? Ziad, it looks you have question. Unmute yourself, Ziad, and go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much. First of all, I would love to send my warmest greetings to the Department of Pediatrics in King Fahd Armed Forces Hospital. Secondly, I would like to thank Dr. Waad for this very informative presentation. What I have is just a comment to emphasize my take on this nice presentation. So whenever we have a progressive renal deterioration in any patient with the underlying liver disease, especially if this patient is having diuretic resistance ascites, I think hepatorenal syndrome should be suspected. And of course, the best therapeutic option is liver transplant. While listing this patient for liver transplant, I think this patient should undergo renal replacement therapy and vasoconstrictor, or even may require surgeries such as what Dr. Waad mentioned, transjugular intrahepatic portosystemic shunt to decrease the portal hypertension. Thank you so much.
Shukran, Ziad. Dr. Mishar Al-Afan and Dr. Yaqub. While Dr. Mishar is opening the mic, there is someone, his name is Dr. Campbell, asking me, was there fibrosis in the biopsy? No, in our biopsy here there is no fibrosis, and progressive familial intrahepatic cholestasis type 2 was a differential, but it couldn't be confirmed with the biopsy. Dr. Abdullah Ahmed, could hepatorenal syndrome occur in acute liver failure without portal hypertension? I will leave this question to our GI team.
Again, what is the question?
Could hepatorenal syndrome occur in acute liver failure without portal hypertension?
Well, I think Dr. Waad commented on that. And
types,
yes.
you mentioned it.
Yeah.
Go ahead, Mishari.
السلام عليكم ورحمة الله وبركاته جميعا. الحقيقة حبيت أشكركم على الدعوة الكريمة وأحيي الجميع في قسم الأطفال في مستشفى الملك فهد العسكري جدة. حقيقة مثل ما قال الدكتور حربي ما يعني we don't see that much of hepatorenal syndrome in general in our centers, especially for not a transplant center. However, يعني many of us who worked in a fellowship center مثل زياد برضو, if you worked with the unit in Riyadh, King Faisal, they face it many, and also in the Eastern Province. The best option and solution is actually liver transplant. By all means, all measures beforehand is just a temporary measure. It doesn't work a long way. The more important stuff, we sometimes face chronic liver disease patients who are just in the lingering period, especially those with the congenital disorders that we don't have a diagnosis. And we follow that with all these patients in our clinic all the time. But we need to make sure, especially with the kids who had ascites, is that really rule out other causes, which is very important. So most of the times, rule out any drugs. We have seen many kids who develop or NSAIDs, develop it, or over-diuresis. We get sometimes excited over the night, kid has ascites, we give him without any replacement, or we take off by acidic tapping, like a larger volume of ascites, and without a good replacement plan. And that puts us into trouble and makes us think of hepatorenal. However, it's still one of the causes that is repaired, causes we can fix it rather than hepatorenal syndrome. So this is the most important thing I would like to comment on, because sometimes some weird disorders can happen, especially when you have proteinuria, which is very unusual of hepatorenal syndrome. Then you can consider other diagnoses and treat up accordingly. As you said, so sometimes we face kids who had liver failure, and in acute setting without any fibrosis, they do develop hepatorenal syndrome. And once the liver disease gets better, the kidneys get better, if you are lucky enough. Now, the issue is we have all the time when you are faced with liver failure or you're faced with systemic inflammation or sepsis, it's which one is which. Is the kidneys affected because of the liver, or it's because of the sepsis? Sometimes it's a hard call, and sometimes ICU team helps us out, as well as hematology, by doing the actual factors like factor A to differentiate between the two. For all the medications that has been mentioned, it's all adult studies. So we don't have, except very small studies that talked about vasoconstrictors, especially, let's say, if you are in the ICU and waiting for a transfer, you can try octreotide. Or however, octreotide in a big study did not show, in adults, did not show any good response. Vasopressin, on the other hand, might cause some effect, especially if you are counteracting the peripheral vasodilatation that happens with the cirrhosis because of the release of nitrous oxide and other vasodilator agents. And of course, dialysis remains one of like the favorite short term, especially, and I'm glad that you guys use the peritoneal dialysis. So sometimes we use the big catheters, which is very difficult to insert in coagulopathic patients, which it can be like it's literally life-saving, especially in such case. And I'm glad that you guys managed to do such thing in the ICU. Maybe that's the thing that maybe held up this patient. Any excess fluids, any excess, any abnormal electrolytes can be corrected easily once you're in more control. I'm glad this kid did not go into encephalopathy and made it to the transplant. And I would really like to thank the Eastern Province. They're showing promising results with their service and accepting more patients, especially from Jeddah and other regions from the kingdom. This is the main thing I wanted to talk about, and أعتقد إنه يعني, and I would like to thank everybody for letting me share my thoughts on this very rare and difficult topic.
Dr. Mshal, maybe, and Dr. Shawush can help me with this answer. For the kids, for typical age of TIPS, I never saw it in younger age. Did anyone have any patient who has TIPS before and shows improvement?
For me, no. Usually it's ما أدري عن دكتور شاوش الحقيقة, لكن for me never seen. We've done it. طبعا they do it in interventional radiology, and depend on how comfortable your interventional radiology person is for pediatric patients, and it should be in selected cases, especially when you have significant portal hypertension, because this will relieve your will create a portosystemic shunt that will help with the portal hypertension, but and reverse the splanchnic pressure, so improve your splanchnic pressure from increasing, and hence improving the renal function as well. So the vasoconstriction process kind of helps out. Like you need to be careful about using it, especially with the bad coagulation. Usually they do it transjugular, sometimes the splenic approach. I've used it only in significant portal hypertension, and I once used it not in here, actually in my fellowship. They used it in refractory ascites that was very resistant to everything. We put in a drain that does not improve, and the kid was old enough for the intervention radiology to be comfortable doing it. But it's a tricky procedure. We have, I think, the youngest I've seen doing it is in Jeddah, King Faisal, a 1-year-old who had portal vein thrombosis, but it was a difficult procedure, keep blocking every time. So it's not an easy procedure. It has lots of complications. And once you do portosystemic shunt, you will have the ammonia will not be filtered through the liver. So you'll have increased risk of encephalopathy. So that needs to be accounted. And that's what happened with the patient King Faisal, where they have ammonias in the hundreds, and you're just praying that lactulose will help them out.
Yeah, I agree totally with Mushari, and I leave it to the last option. We did it once with patient with refractory ascites, and as you mentioned, Mushari, that's you do something, and at the same time you harm probably the patient and may go into hepatic encephalopathy. So I think it's very tricky procedures, and usually it is a temporary measure till you transfer the patient to liver transplant. So it may help if you're stuck and you have no choices. At the same time, the patient may go into hepatic encephalopathy.
Just a simple question, just to complete this answer. Can we consider like the tips as in case of a struggle with refractory ascites? Can we consider it as a bridge to the liver transplants, as a living measure to get transplant, as like a temporary measure?
Yeah, exactly. This is what we do. It is a temporary measure to transfer the patient to liver transplant for transplanting.
Okay, let's just go for the other side of hepatorenal syndrome. Thanks to Dr. Shawush and Dr. Irfan for the excellent output always in the GI part. Dr. Haider, if you are still with us.
طبعا معاكم.
I'm wondering, Dr. Haider, if you can tell us about your experience with hepatorenal syndrome from nephrology perspectives. How frequent you see it, and how do you guys deal in dialysis mode in case of hepatorenal syndrome?
So, like our colleague gastroenterologist, I'm also, it's a very rare complication we can see. In the last 10 years in our hospital, this is the first case we saw hepatorenal syndrome. Usually, the kidney injury is functional injury, and it's not, and it's severe renal vasoconstriction secondary to the severe arterial or systemic vasodilation. And this make the perfusion to the kidney is very little, the GFR decrease, and that's why there will be sodium retention and the sodium restriction will be very low. Why we should look for proteinuria and the urine sediment? It's to rule out other causes, because usually when the patient is sick in ICU, so we expect that the patient have kidney injury secondary, for example, to sepsis, to medication, to other things. So if we have proteinuria, so we have to think about glomerulonephritis, and to think about other kidney injury, and that because the treatment is much different between hepatorenal syndrome and, for example, glomerulonephritis secondary to hepatitis or severe liver problem. We had before a patient, if you remember, we have a patient before with severe acute glomerulonephritis secondary to hepatitis B, and we managed him with Dr. Shawush. And that it was much different, and the management is much different, and he didn't require a lot of management from, we did temporary dialysis for him, but the management probably it was a treatment of hepatitis B. It's different than hepatorenal syndrome like now. So it's a very rare complication that the main treatment is the liver transplant, and it's to fill and waiting the renal transplant, the liver transplant is you know, we have to make vasoconstriction, systemic vasoconstriction, fill with albumin to make the GFR better for the kidney. Usually dialysis, we prefer PD dialysis because because usually in CRRT we are afraid from bleeding and complication of bleeding and all of this. PD dialysis, we can manage the ascites and the toxins with the PD dialysis at the same time, so it can help us like we did with this patient. Usually, because we are saying the main problem is functional, so we have big chance that the kidney will recover after the liver transplant, unless we take a lot of time to do the management of the liver, and then the injury of the kidney, it will be permanent. There is many patients, we are not doing biopsy because like we are saying, the lesion is functional, it's not a tissue lesion. So if we did a biopsy, we will not found any specific lesion, and usually it's risky because of a bleeding problem. Usually all the tissue taken on autopsy after the death of the patients, it didn't show any specific lesion for the kidney. And sometimes, and usually this we did it in France, for example, we took the kidney from this, for example, if a patient died from Hepatorenal Syndrome, they took the kidney and transplanted to patient with renal failure. And after a couple of days, the kidneys recovered normally. You know, this it would tell us like this is the problem. It's not kidney. The problem is liver, and the kidney is only have secondary damage from the liver. So for the kidney, the most problem, the most important is to manage the liver as soon as we can, and to keep the very good volume, intravascular volume, with vasoconstriction, with albumin infusion. And to manage the toxins, to stop all the toxic medication. And like we did, for example, we do PD dialysis. It's case by case because there is no consistent management for the kidney, because if each patient is different than the other one, and this is very rare disease. So this is from our side.
Thank you, Dr. Haider, for your input. It just, yeah, for us as intensivists, maybe it is a little not the best situation for us to put a VAS cath in a patient with INR of 4. It is not our best option at all, and we don't like to go for these options. But sometimes if you need to save the life, we'll do it. Just, I read the name of Dr. Intisar in our chat. I'm wondering if Dr. Intisar has any comment or questions. If you are there, Dr. Intisar, unmute yourself.
Hello, assalamu alaikum.
Salam wa rahmatullahi wa barakatuh.
Hi, I'm very happy that I'm attending this webinar. I was not lucky to attend the previous one. وربنا يعين إن شاء الله. No comment. ما شاء الله وعد قدمت تقديم كويس. وكنت أتمنى أسمع من الليبر عند transplant people around or something like that.
They have problem with the issue. I think his phone is not iPhone and he's struggling with entry. That's why he sends it in WhatsApp.
Okay. Allah يكون في العون ما شاء الله. Well done, good management ما شاء الله.
Dr. Rehab Binafi asking our maybe GI team, what about the genetic predisposition? Is there any genetic predisposition for the hepatorenal syndrome? Dr. Mishari or Shawush, whoever have an answer, he can unmute himself.
I don't know. I cannot answer this question. I have no idea.
Neither do I.
Thank you, Dr. Yahya, for making impossible question. I'll move to Dr. Rosie if he's around with us. Dr. Rosie? Ibrahim? Looks Ibrahim is not. Ibrahim Rosie? Dr. Rosie? Looks Ibrahim Rosie is not with us anymore. Anyone have any more questions before we close this session? No raised hand, no question.
maybe
I
Adi,
just have a
for
comment. Oh, sorry. تفضل دكتور شاوش.
maybe to make it more interesting, this patient was having severe leukopenia and very, very low neutrophil. So that's to make it more interesting cases. And we were struggling with this patient of severe leukopenia and severe neutropenia, and reached even absolute neutrophil was less than 100. So that's another thing. I don't know, it's part of the sepsis and part of inflammation or infection this patient is having. But alhamdulillah, this patient recovered very well.
Our intensivist Dr. Manal now is merging. MashaAllah, she is the one who has initiated the idea of these sessions to help our collaboration as a team. Dr. Manal, please go ahead, unmute yourself.
Thank you. I just wanted to say thank you to everybody who attended, and Dr. Adi for supervising and running the show, and Waad for all the work that she's put in to prepare it. I just had a follow-up comment after Dr. Haider. We have lots of residents on board, and I just wanted to make sure that we leave with the message that you do really have to have an index of suspicion when you have a liver failure and renal impairment. So yes, the kidney is not the problem, but you still have to support the kidney and all the function of the kidney. And I think Dr. Haider made that very clear. Managing the drugs that don't need to be on board or adjusting the doses and so on. It was a great management by the PICO team to collaborate with everyone. So thank you. I just had a comment.
Thank you, Dr. Manal. Abdullah Ubeshi, please go ahead. If you have any question or comment, unmute yourself.
Thank you, Adib. Thank you, Manal. Thank you for all the pediatric team and our team from gastro and nephro section. Thank you, Waad, for your nice presentation. I have no comment for this discussion after all the gastro comment and Dr. Haider and our PICU. Thank you so much.
And I'll open the book and I'll keep it open there. I will not answer what I'm going to open right now, but I'm going to open it for everyone to think about it. Surprisingly, this patient, when arrived to Eastern region, the bone marrow was sent with him, and he started to have high ferritin, high bilirubin, high triglyceride, and his bone marrow was going with HLH criteria. So was it primary HLH or secondary HLH? No one knows this answer. He's lucky enough because this result was released after he get transplant. Otherwise, the transplant team was telling me that that's why I was hoping that they will conjoin us, but unfortunately they couldn't. They said if we find him HLH, maybe we'll hesitate to do transplant first before treating HLH. But he got the transplant before HLH. In the way to transplant, this kid has rising bilirubin up to 1,000. He get double times exchange transfusion, and then he settled down. They are able to do the liver transplant. Now he's receiving both treatment for liver transplant as HLH also management. They believe it's secondary to the hepatic failure rather than it's primary HLH. That's the open book. I'm going to keep it for everyone to think about it, or anyone has any comment about the relation between the two before we close our session. Everyone have comment, he can unmute himself. Abdullah, Mshari, Dr. Manal, Dr. Shawush, Ibrahim, Ziad. Any resident has comment? Dr. Shawush, you are moving your head. I don't know if you want to talk or not. Say like this if you want. Okay.
Well, I think most likely this is secondary HLH rather than primary HLH, because this patient was having really severely fulminant hepatic failure leading to secondary HLH. Anyhow, input of hematology, oncology team probably, and even from bone marrow, maybe they can tell us if it is primary or secondary. But for me, it is secondary.
I believe it's, I say to the hematology team, will review his all of criteria, all of his lab in our hospital. He's not fitting the criteria at all. But there, with progression of his illness, they could pick it up. He was meeting the new criteria of HLH. I have Dr. Tariq Al-Hazmi is joining us also. Dr. Tariq, are you on the board? Dr. Tariq, unmute yourself. Dr. Tariq Al-Hazmi, Dr. Tariq, if you are hearing us, I just want to take your experience. How frequent you met the hepatorenal syndrome in Mecca? I think he couldn't hear us, Dr. Tariq. Dr. Yahya Benafa, he comment. Any intensivists want to give us any comment about hepatorenal syndrome in the past few years? Looks like no one has comment or question.
Just a question, Dr. Adib, على الحالة. Was there يعني in the past for this patient, يعني neutropenia can be one of the manifestations of acute liver failure. Bone marrow suppression can happen during the acute liver failure situation with unknown cause during the time. So some people sometimes they jump into steroids in such situation, trying to like salvage whatever. The problem with steroids in an acute liver failure is the rate of death and encephalopathy. So you are going to use a gun, but are you going to use it like it's a double-edged sword? You can kill the patient, or you can make you can reverse the etiology. So it's hard. So for this patient, like one of the things that we see sometimes, if the neutropenia has been chronic or hemolytic anemia, sometimes we see it with the youngest forms of autoimmune hepatitis. So like there is several forms of autoimmune hepatitis that present early, sometimes in the early age of even less than a year of age, and we start steroids early, but sometimes even we cannot succeed. The reason I'm raising this is that, and I wish that the transplant team could make it, because sometimes when you are transplanting an autoimmune hepatitis, you are at higher risk of developing post-transplant de novo autoimmune hepatitis, something out of the bloom. So you develop autoimmune hepatitis again. We don't know why, but that's one of the things that can affect our. So my question again, was there any evidence of autoimmune hepatitis in this kid for the liver biopsy? You managed in a very difficult situation.
Yes, Mushari. I thought about it from the beginning, that possibility to be autoimmune hepatitis, especially all viral markers were completely negative for this patient. And I was so hesitant to start this patient with discussion with PICU and nephrology to start the patient on a steroid, and aiming for this patient to be accepted by liver transplant center. And actually, when we get approval for transfer, and we thought better not to start steroid, and we leave it to our colleagues in liver transplant to make decision. And yeah, and actually, it was in my mind that one of differential is autoimmune hepatitis, but as you said, it is a bit risky if you hit in dark. Thank you.
We kept this gun, actually, Dr. Mushari. We discussed it, and we said if we didn't get the transplant for this patient or in the end stage, we're gonna give him the gun, and regardless whatever the result. But alhamdulillah, I get accepted, and we didn't need to use it. Dr. Ali Sahafi, are you still with us in the board? Dr. Ali is not there anymore, I think. I saw his name before, but he left. Anyone has any more comments, guys? Any questions? Otherwise, I'm gonna end the session by thanking Dr. Waad for presentation, thanking all the Dr. Mushari, Dr. Shawuz, Ziad, Ibrahim, Dr. Manal, Dr. Intisar, Abdullah, and all of our resident fellows and registrar for attending. And inshallah, we'll meet with you soon with another session. Thank you all, and God bless you all, inshallah. Stay safe and good luck, inshallah, to all. Thank you.
Thank you. Thank you all. Bye.